Welcome everyone, I'm Andrew Duckworth and I would like to thank you for joining us for our second instalment from our follow-up podcast series on the COVID-19 pandemic, which is entitled COVID-19, the New Normal and How to Get There. Through this second series of podcasts, we hope to reflect on what has happened so far as a consequence of the pandemic, for us in orthopaedic and trauma surgery, as well as on our healthcare system as a whole. You'll hear from a range of colleagues and specialties on how we may best move forward as we start to consider restarting or increasing our orthopaedic services around the country. There are several questions and unknowns regarding our hospital and staff capacity, patient safety and prioritization, as well as our ability to restart the various avenues of research that were being undertaken prior to the pandemic. So today I have the pleasure of being joined by our Associate Editor for Trauma here at the Journal, Professor Matthew Costa from Oxford, who I know will be able to give us an exceptional overview and insight into the effects of the pandemic so far, particularly on the effects on research and the hurdles we're going to face in our attempts to return to some form of normality with regards to this. Many thanks for joining us today, Matt. We really appreciate your time.
Thanks, Andrew. Pleasure to be here. Thanks for inviting me.
So, Matt, if we sort of start off, it's well over 2 months since the first recorded death due to the COVID-19 pandemic, and a lot continues to develop and change in the UK and the world during these difficult times. So, can I just start with asking what your experience has been of the pandemic over the past few months from your setting in a large, research, active, major trauma centre?
Yeah, thanks, Andrew. It's certainly been interesting times, hasn't it? It's sort of major changes for life as we know it, really, never mind within the NHS. I'd say I consider myself quite lucky compared to many of my colleagues in trauma and orthopaedics, because my practice is entirely trauma these days. I've been able to carry on doing the J job to a large degree. I haven't been redeployed to do anything else. So having said that, we've got a very different rota. We realised very early on that we had to, I think, protect the patients from COVID, and I think we learned quite early that protecting the patients who were still coming to the hospital who didn't have COVID problems from the response to COVID was perhaps a key priority for us. So, for example, there's a good reason why we want to operate on hip fractures quickly and get them up and out of bed and back on their feet and out of the hospital as quickly as we can. And those reasons are no different when we've got COVID going on than they are at any other times. Whereas other conditions may not present, so sports injuries almost dried up really for us. Yeah. So yeah, we got to grips with that relatively quickly, and then the other factor was we had to really sort of protect the staff as well, really. So having rotas that kept as many people out of the hospital as possible, whilst maintaining the key services, different ways of working, and so on, direct referrals from minor injuries units and so on. And then I guess the other big change was the precautions, really, just realising that. How slow things were going to be to do our normal operating and so on, just because of the extra precautions. And also, and it sounds like really small beer, but you only have to put your face visor on, touching your ear, to realise 3 hours later that that's damn sore. So Absolutely. Actually getting used to the new precautions has been a big change. I guess in terms of the type of trauma we're seeing, that's been quite interesting. There's almost no sports injuries, whether they're all saving them up or not. Hardly anything really from there. Minor injuries units or referrals have been still happening, but far fewer. Major traumas less, although just starting to pick up, I would suggest.
I agree. Yeah.
But the fragility fractures have kept coming, and I guess there's some arguments said there's probably even more of them as people who previously had better home support are trying to struggle to do things over long periods by themselves. So yeah, the fragility fractures, hip fractures, and so on have not really changed. So yeah, quite different, but I consider myself lucky to many of my colleagues with more elective practices who perhaps had a heavier hit in terms of being asked to do things and don't normally do as the day job.
No, I completely agree, Matt. I think we found that up here. You do feel very lucky in the fact that we're still having some normality to our day-to-day practice, particularly in trauma. And I'd sort of echo what you said. I think we found very much the same up here in terms of that decline in those other types of injuries, but the fragility fractures just do seem to keep on coming through the door, and nothing really has changed with them. And like you say, sort of emphasising what we've done already, but the importance of getting these patients through the system as quickly and as efficiently as we can.
Yeah.
So moving on sort of back onto the research side of things, which I know you'll have great insights and a lot of experience with. Could you summarise what sort of has happened in your centre and I suppose nationally as well with regards to research, and particularly the larger UK multi-centre trials that you're involved with?
Well, I think the NHS quite rightly has had huge sort of plaudits over the last few months. there's been no applauding of NHS staff in our house, I have to say, but it's very heartwarming to see people doing that around the country. That's great.
Yeah.
I think the NHR, as the research arm of the NHS, has perhaps been the unsung hero here, and I, for one, am incredibly proud of what they've done behind the scenes to engage and mobilise in a reasonably coherent, in fact, very coherent, if we're honest, way, a national infrastructure like that. Well, to be honest, it's unique to have the opportunity to be able to mobilise a national infrastructure. I'm thinking particularly the clinical research nurses through the clinical research network who were redeployed out of their comfort zone and with no fuss at all. They were amazing to recruit patients into COVID studies on a scale that no one else has been able to match around the world. So just this morning we were discussing the latest figures. There's now 60,000 patients have been recruited into COVID studies in the UK, which is more than anywhere else, and is really remarkable. So yeah, very proud of the NHR response overall, and particularly the clinical research network. I think very much unsung heroes in this. In terms of what's happened for national research, a bit of background might be of interest to the listeners. So the decision was made 10 weeks ago to create a COVID urgent public health committee to review all applications for new research in COVID from around, well, it's England, but it's involving the devolved nations as well. They've all got representatives on that panel, and that's been hugely helpful. And they reviewed all of the studies related to COVID that were coming through the pipeline. And just to give you an idea of the scale, at one point there were 400 studies awaiting review.
Wow.
Literally hundreds of people with some really, really good ideas, but many of which required resources that didn't exist, to patients that couldn't be identified, and a lot of them were overlapping. So of those, 33 were narrowed down, including several platform studies to test multiple interventions. So that's having a single cohort of patients, say COVID patients admitted to ITU, for whom this platform could be used to test multiple different interventions in parallel. So an efficient way of doing that. And that was set up very quickly. And those 33 are now open and recruiting, as I say, over 60,000 patients, which is just amazing. Unfortunately, the corollary of that was that the clinical research network infrastructure was essentially turned off for all of the other non-COVID studies, which I think was the only sensible decision. And that really, was the only thing to do. But that meant that essentially TNO research in the UK is all but stopped.
Yeah.
And that's been a huge frustration for me, for you, for the journal, for everyone that's involved in that world, which is actually most of the clinicians in the country these days. But I think was the only sensible thing to do. In terms of what's happening locally in Oxford, Oxford's had quite a big part to play in a lot of the national studies. There's a lot of huge vaccine research infrastructure in Oxford, and which has swung into action. And a lot of the platform studies have been based around here as well. So Oxford turned off, as in literally stopped, every other study in its tracks straight away. And there was a process to apply for exemption through safety concerns. So we've got one stem cell study, a European project that's carried on, but only for safety follow-ups. And that's it. Everything else has been turned off. And I think that's been mostly the experience around the country.
That's interesting. So in terms of, I would say, like certainly any new trials or trials that are recruiting that all commence, have you managed to maintain any sort of follow-up for the other trials that were sort of ongoing at all? Has that been possible, sort of, like as your colleague Dan has done with, sort of using remote sort of follow-up? Have you considered anything like that, or been doing anything like that?
Yeah. So we're quite lucky. We made the move quite early to doing electronic follow-up as much as possible. And where there are patient groups, hip fracture, for example, where that doesn't really work, then we had remote follow-up via telephone. So through centrally, we've been able to carry on follow-ups for most of those studies. It's just where you're relying on research nurses, essentially, or infrastructure inside the NHS to do the follow-up. That's really been impossible. So yeah, absolutely, yeah. And I think this is one of the things that will change in the longer term, is that move towards remote electronic-based data capture. I think it was happening anyway, but it's going to accelerate because it's the only really way of doing it under these circumstances.
No, absolutely. It's interesting in these times of sort of national crisis. It's a bit like some people liken it to wartime, don't they? You often do move forward with certain things, don't we? And like I know, like you say, Dan has done sort of the remote follow-up, but electronic follow-up. But I think that will probably be a big step forward as we maybe a good thing to come out of it. Do you think in the future?
Yeah, absolutely. And it's been interesting. Moving to electronic data capture doesn't necessarily improve your follow-up. different, but if identifying at the beginning which the individual participants' preferred method of communication is, that is really helpful.
Yes.
And for some studies, like Dan's work on the FORCE trial, which is forearm fractures in children, that's electronic because it's young parents or parents with young kids, and so they all do it that way. Whereas you need a different mechanism for fragility fractures and a different mechanism again for major trauma patients. So it's not don't want to go too far. It's not the panacea for follow-up, but absolutely, it also has huge methodological advantages in terms of reducing transcription errors and so on, and governance is better. And so, massive advantages. I mean, we've pretty much moved all the new studies these days to electronic consent, electronic data capture across the board, just because it's easy to manage.
Yeah, no, absolutely. So that leads into Matt, sort of moving forward. What do you think in terms of, as you know, obviously things are starting to change in terms of lockdown, and we're trying to move forward a little bit with the pandemic, and obviously there could be, probably will be hurdles in the road, but what do you think the short and longer term sort of plans will be for us to get back to those routine research activities? How do you think we're going to be able to do that, and what sort of timescale do you think? I know it's difficult, but
well, it's a good question. And there's a draft framework that the National Institute of Health Research have created about resuming the studies that were paused, including the trauma and orthopedic studies. This has been reviewed by the Chief Medical Officer, and it's a framework. It's not a didactic list of indications for resuming research or priorities and so on. Each centre will have to work its way through that on the basis of its own infrastructure, its own COVID activity, and its own priorities. But the framework essentially says that pause studies, so those studies that are already on the NHR portfolio, will be reopened first, and newer studies, I'm afraid, will have to wait for their approval. And priority will be given to studies involving usual care pathways. So if patients are still coming to the hospital at the moment, then they will be a priority because those patients are there anyway. Whereas if those patients at the moment are not being seen, so some elective services are not seeing any patients at the moment in certain areas, then they will be, obviously it'd be sensible to keep those on the back burner. Yeah. And the other big factor is safety. So some studies have a higher safety risk than others. And that would include studies that involve surgical interventions. So at the moment, it would be difficult to justify doing research interventions in the operating theatre when there's reduced resource. So all of those factors. But there is a plan behind the scenes, but it's not going to be a very straightforward roadmap. There'll be a lot of bumps along the way. Yeah, I think that is likely to start actually next week, right, in terms of reopening some of the TNO studies. But the idea of getting back to normal service, well, I'm not sure that's ever going to happen. And it's going to be months and months, even if it does get back to anything like we experienced before.
Yeah, no, absolutely, Matt. And just going back to what you mentioned before about staff, obviously, a lot of the staff have been redeployed, whether it be to clinical, the clinical front line, or other studies, COVID-related studies. Obviously, there's quite a big challenge there, isn't it, in terms of reintroducing them back into all the various projects they're involved with. Would you agree with that?
Yeah, I mean, some of them have had, I think they've coped amazingly, as I said. I'm very proud of the CRM response, particularly research nurses. But some of them are going to have trouble getting back into this. There's going to be a time for recovery and recuperation after some pretty, distressing and taxing sort of times. Spending all day, every day on the COVID wards is not tough. And I know that applies to research, people outside research, but to the research nurses as well. So that's going to take a while. But I think my experience in talking to our teams locally is they're desperate to get back. They've actually realised that TNO research is not, although it's got its problems and its difficulties, it's not a bad place to be in the greater scheme of things, and they're desperate to get back to the day job. So I think most of them are looking forward to getting back onto the trauma and orthopedic wards and seeing our patients and dealing with musculoskeletal problems again.
Yeah, absolutely. Absolutely. And so moving on from that, Matt, in terms of, I suppose, the trauma, we've already touched on it briefly, but the trauma and orthopedic related COVID research that's already been out there, sort of either been submitted to a journal that you've seen or published already, how would you what do you think of that so far in terms of summarising it for our listeners? What do you feel has been put out there so far?
Well, I think because the response from the infrastructure in terms of both funding and support by research nurses has been on treatment and diagnosis of COVID itself, then that's meant that the really intensive studies have not had resources in TNO.
Yeah.
However, that's not to say there's not a lot of really useful TNO research into COVID that could be done. So I'm thinking for the future, a better understanding of how transmission works, both for patients, what is their risk of coming into the hospital, what is their risk of catching the disease, what is the risk of passing it on if we've already got it and they're asymptomatic, and equally, what is the risk to staff of different procedures? Because we've all, I think, quite sensibly moved to a fairly extreme view that we're using precautions for any procedure involving power tools, which is, most of what we do.
Yeah.
But is that really necessary, and is that sustainable in the long term? Well, we need to know it's safe before we change. So I think there's a lot to be done there.
Yeah.
In terms of what's been published, I think we had some interesting reports come through of changing activity.
Yeah.
If I'm honest, I think most of us were living in, well, not breathing it, carefully breathing through masks, but certainly that work, that experience has been reflected across the country. Trauma's kind of kept happening and elective hasn't. And so I'm not sure we need many more reports on that, really.
Yeah.
I think that moving towards a situation where we're addressing those issues of transmission and how to really put an evidence base behind resumption of elective planned interventions, I think would be really helpful and something I'd be keen to see from the community. I know there's quite a bit of work going on in our area behind the scenes.
That's interesting. We were talking with obviously Professor Haddad on our first podcast, and we were talking about that very, very thing in terms of how it's a big unknown in terms of our ability, particularly for our elective patients, to quantify risk for them now in terms of, what was a routine hip replacement, knee replacement, how do we quantify risk if they unfortunately do catch COVID? What is that moving forward? And it's obviously data is very much needed there. Would you agree with that?
Oh, I entirely agree. And, I think I mentioned that some TNO research will resume and some won't, or certainly will change forever, I think. And I think, I don't think the NHR and the major funding bodies are going to change dramatically in terms of their mission statements and so on.
That's interesting.
That's not going to be huge. But what I think will change is the patients and the patient's attitude towards interventions, particularly surgical interventions.
Yeah.
So I'm thinking that if you're having a procedure, a planned elective procedure, or even a trauma procedure that's not life or limb threatening, on the basis it might improve your outcome in the future, I suspect patients are going to want to know with more certainty that it will benefit them, rather than it might do, given that just coming into hospital at the moment is a risk. And as I think Faris mentioned when you did the podcast with him the other day, latest thought is that the risk if you catch COVID in the hospital during the surgical intervention puts you in a very bad position. So that's not something patients are going to underestimate. So, it may in a way accelerate what we're already doing. So we started in the UK doing research into relatively low-hanging fruit in terms of comparing two interventions that were routinely available. And the move towards doing perhaps more fundamental questions about, do we need to operate at all here, or is there an alternative strategy, has been slower. And it's often held back by the surgeons as much as patients, but both need to be reassured that not operating is a sensible thing to do, or at least a reasonable alternative. And I think the patients may start to vote with their feet here and actually accept those studies perhaps more than they would do before. And it's up to our community to support those decisions from the patients. So I think there will be long-term changes. I think patients' priorities will drive the way that research changes in the future.
Absolutely, no, 100% agree. And you mentioned just the funders there. So your gut feeling, Matt, is that you don't think there'll be a sudden sort of over-focus, shall we say, on COVID-related projects. They think that they're still trying to maintain that breadth of funding as best they can.
Yeah, I think so. So I don't. So in the short term, the UKRI has put money aside, new money allegedly, we'll see, to support the COVID studies. So the platforms that so on are funded through new pots of money, which are new grant allocations. And NIHR has said reasonably clearly, or very clearly, that there'll be uncosted extensions to all existing NIHR projects as the default. So no studies are going to get cancelled automatically. Having said that, there are maybe some studies that actually, unfortunately, turn out to no longer be feasible if the patients are not there and not going to be there for a while. The emphasis on funding COVID research is not going to disappear in the short term, because there's, I think, widespread, and this is worldwide, not just UK, acceptance that this is going to go on for a while, and we'll have new cases coming into hospitals, but also primary care in the community for quite a long time to come. And so there will be ongoing emphasis on COVID, and probably quite rightly, it's difficult to argue against that.
Yeah, absolutely.
So I don't think NHI is going to change its mission to, improve the health and wealth of the nation, and that will involve prioritising areas of research, to be honest, like TNO, that don't have natural homes in major charities like cancer and so on.
Yeah.
Certainly trauma doesn't. So versus arthritis, obviously very active in some areas of MSK research. I guess the big worry is the economy, really, and the economy of healthcare and research behind it, because it is going to cost money to maintain the ongoing trials at the moment. And will there be another pot of money to fund new projects in the future? The truth is, I suspect that's unlikely, really. Although at the moment everyone's celebrating the NHS and to some degree the NHR as well, whether the politicians can really prioritise over everyone else and everything else in society, who knows? So I guess there is a genuine concern about levels of funding for research across the board in the future, but I don't see the emphasis on inclusivity for all parts of society and addressing issues that other major funders don't address, including musculoskeletal, won't change for NHR and so on.
That's interesting. And so, Matt, just sort of to finish off, really, and I always try to ask, our guests this: what do you? And I know it's very difficult because you can't predict the future. What do you see? Maybe over the next couple of months will be the road forward for us, both as NHS, but in particular trauma and orthopedics. And what do you think the bumps in the road will be for services? Moving away from research, and do you have a feel of what maybe our new normal might look like in any way?
Yeah, so it's going to be interesting times. It's constantly interesting. I guess the big worry for me as a trauma surgeon, one of my colleagues working, in trauma, which I think is most of the TNO surgeons around the country, is we're anticipating a rebound, a bump.
Yeah.
Here as lockdown eases to a lesser or greater extent, then I think people, are going to understandably get out there and start breaking things, perhaps in even greater numbers.
Mm-hmm.
We're also slightly worried about not the major injuries, the open fractures and the hip fractures and so on, but people ignoring things that would have come to hospital before because they've been understandably nervous. And so late presentation of all kinds of things, I think we're pretty worried about that, and already start to see a few people with, even quite big injuries, forearm fractures that are just presenting late with the problems associated with that. So I think we're a bit worried about that in trauma. I think the reality is our slower turnover through operating theatres in particular is going to be a long-term issue. So kind of worried about flow there.
Yeah.
For my colleagues working in elective services, planned surgery, I think trying to work out what the priority is for patients on waiting lists and so on is really difficult. And there will be a natural tendency to fall back on specialty areas, groups. So, my patients in knee world are more important than yours in shoulder world and so on. But actually working out a coherent strategy across whole elective services to plan that is going to be tricky. And that's, BOA is already active in there at the moment with a lot of support from specialist societies. And I think that really does need to be coordinated to make the best choices there for the patients. Having said that, I think some of the things that have changed already will be long lasting and to the benefits of patients. So we've already in Oxford moved to a system whereby we're seeing pretty much every referral at the front door. Right. And that includes teleconferences with the minor injuries units around us, so that definitive treatment plans are instituted immediately. And in the same way, follow-ups plans are being made by consultants initially. And so limiting follow-up, and where follow-up has been done, it's been done by video conference wherever possible. Yeah. And quite honestly, why would patients not want that going forward in the future? Why come back to a new patient clinic the morning after you were seen in the emergency department that evening, and why come back to be told by me, yes, it's perfectly safe for you to move your wrist, when I could tell you that over the phone, and my physio colleagues could give you some exercises and some advice. So there'll be benefits in the long term, and we're already starting to think about that. And I think a lot of places are moving towards those systems and will continue to do so. Yeah. But I think we're in the short term pretty worried about capacity in the operating theatre, particularly. Yeah. For my colleagues in elective practice, I have great sympathy with them trying to wrestle with this conundrum of, which priorities are the biggest, and how do you compare one patient with another? It's really difficult.
Very difficult. No, I totally agree, Matt. Well, Matt, I think that's actually all we have time for. So thank you so much for your excellent overview and insights today. It was really fascinating and really informative for our listeners. So thanks so much for joining us, Matt.
Oh, great pleasure, Andrew. Thank you very much.
And finally, as always, we'd like to acknowledge and thank our many colleagues around the UK and across the world for their tireless ongoing efforts over the past few difficult months in the delivery of care to our patients during this pandemic. We at the Journal thank you, and we'll continue to support you in every way we can moving forward. Stay safe and well, and thanks for listening.